Okay, so our next speaker is Dr. Thomas Kosten. He is the J.H. Wagner Chair and a professor of psychiatry, pharmacology, immunology, pathology, and neuroscience. He is the director of the Division of Substance Use Addictions and emeritus director of the Dan Duncan Institute for Clinical and Translational Research at Baylor College of Medicine. He is the past president of both the American Academy of Addiction Psychiatry and the College on Problems of Drugs Dependence. Dr. Kosten is a longstanding member of various commissions with the National Academy of Sciences, the Food and Drug Administration, the Federal Trade Commission, and the Department of Defense. Dr. Kosten is the current editor of the American Journal on Addictions. Please join me in welcoming Dr. Kosten.
Thank you very much, and it's a pleasure to be here, particularly with it being non-white precipitation that's outside. That was my major concern, but a little extended Indian summer was okay with me, since Houston's a little bit warmer than this. So I'm going to cover things that are really going to focus on the human studies. Like Gary, we've been working on vaccines for quite a long time. With the cocaine vaccines, we were a little ahead of the curve in that we had done all the preclinical studies quite a number of years ago and have been in humans, have gone all the way up through multi-site national phase 3 studies. And as Gary was hinting at, these are not standalone treatments that are going to work that well. So in fact, our investors and various other people stepped aside and we abandoned the cocaine vaccine at that time. But we did have quite a bit of experience with humans in it, and so we can talk about what some of that is. So rather than overwhelming you with the kind of depth of science that you were just hearing about, I'm going to try to focus on the clinical trials and raise some of the issues that have been perhaps closer to the ethical concerns that I think you'll hear about in the next talk. All right, with that as the beginning, I'll try to push the correct buttons so that, in fact, the slides come up. Yes, okay, so this is some of the disclosures that I have been a consultant to a number of companies, including Opiant, which is the company that has the rights on Gary Magnus's vaccine right now. And my support right now is the NIH and the Department of Defense. Quite a bit of learning objectives that I've put here. And hopefully some of them will go quickly. First, showing how the vaccine antibodies block drug-induced euphoria. One thing that Gary hinted at is it's not simply a big sponge. There's a very important pharmacokinetic effect where if you slow the entry of these drugs into the brain, they are not at all reinforcing. I mean, oral cocaine is what the Indians take in the Andes. They don't get a high from it. It is much more rapid routes of administration that are required. And much of what these vaccines do is slow the pharmacokinetics. So it's as if when you're smoking the drug, you're instead taking it orally. And that slowed kinetics makes them much less reinforcing. I'll talk about ethical issues of medical safety and stopping rules during these vaccine studies that depend on antibody titers in the urine toxicologies, and ethical review of the subject recruitment for these experimental anti-cocaine vaccine studies, which have now, I guess, been generalized to all these anti-drug studies. Ethical choices in vaccination for therapeutic versus preventative community roles, what are realistic targets, and we actually wrote a book from the National Academy of Sciences now about 20 years ago about what these issues were when we first started getting the human studies going. And then I'll talk about the review of the FDA regulatory advantages in comparing therapeutic versus preventative vaccines. So again, just to restate what I said, abuse potential follows the speed of brain entry. So oral is much less reinforcing than intranasal, than intravenous, than smoked. Smoked is the most reinforcing because the drug gets into your lungs, and from your lungs, a blast goes directly to your brain. So that is the most reinforcing. Crack is simply smoked cocaine already converted to the free base, and so it's a very rapid entry. The oral stimulants generally are not reinforcing for getting a high. You need a much faster onset, so the kids who are taking stimulants for attention deficit disorder, for example, are not getting a high from that. It just doesn't slow. And again, slowing the drug entry into the brain. That's an important component of antibodies that goes beyond just simple sponge effects. So this is just an illustration for cocaine. What you're looking at is the blood levels of the cocaine if you take it in a smoked form, and that's the big peak that's there. And the other is if you take the cocaine either intranasally or if you, in fact, eat it. And what you can see is huge differences in the amount of what that peak effect is. And those same curves would be equivalent if you were looking at high instead of blood levels. All right? So it's very much dependent upon how you take the drug, how you get it into the brain. And this is an interesting graph in that it's a little difficult perhaps to see, but you can see there's a blue line that's there, right? And what you're looking at is that the drug effect, you can vary the drug effect even when you give it intravenously based on how fast you give the drug. So the faster that you inject the drug in, so if you have an infusion rate of, say, 60 minutes, it's not very reinforcing at all. On the other hand, if you have one that's 2 minutes, you in fact get quite a bit of reinforcement from that. And so, and of course, when you smoke the drug, you get it not in terms of minutes, but in terms of seconds. That is, you're getting it in about 30 seconds. So it's extremely reinforcing when people smoke these drugs. This is some human laboratory studies that we did. This was in collaboration with Columbia when I was at Yale. And what we did is we looked at people where we, in fact, vaccinated them in such a way that they would either get a high level of antibodies or a low level of antibodies. A simple dose of what vaccine we gave them. And what you can see is a dose response, which is what we hope to see. That is, if we gave them more of the smoked cocaine, that we would get a greater effect of the drug, even with the antibody there. So briefly, what am I showing you here? Again, left is high antibody. Left is high antibody, right is the low antibody. The blue is week 3. This is before the antibodies have risen. So it takes, with this particular vaccine, it took 3 boosters, and when we gave those boosters, by week 13, which completed that series, we had very high levels of antibodies if they were getting the high dose of the vaccine, modest levels of antibodies if they got the low dose. The orange bars are what happens when you have the antibody there and you have them smoke the cocaine. With the high dose antibody, what you see is that one big bolus of cocaine, which would be 25 milligrams in this case, you'd get an 80% reduction in the effects of the high, but it was not very reinforcing at all. On the other hand, if you doubled the dose of cocaine, you'd get about a 50% reduction. Okay? That's the dose response that we like to see in terms of amount of antibody does make a difference. On the right side is what if you had low levels of antibodies. And what you can see is that you only get about a 20 to 15% reduction in the high at the high or the low dose. Those are not significant reductions in the high. So you do have to get higher levels of the antibody in order for it to work. And so you see a dose response on antibody level and a dose response on the amount of cocaine to override it. That's the kind of pharmacology one hopes for, and this was a study that was difficult to do. All right, we then looked out in a whole variety of clinical trials we did. There were hundreds of people that we vaccinated over the course of these trials, and what you're looking at is the percent of cocaine-positive urines. That's what's on the vertical axis there, and on the horizontal axis is what their level of antibody was. And very simply, as the level of antibody goes up, the amount of cocaine in their urine goes down. All right, so they're just using less and less. Surprisingly, people can learn That is that when they are out in the free world where they can get as much cocaine as they might want to purchase, they in fact start purchasing less and less cocaine and use less and less of it when they start to realize, oh my goodness, it's blocked. Till when you get to very high levels of antibodies, they in fact finally learn, gee, it's not worth using the cocaine at all, because I'm not getting a high from it. So you can, in fact, extinguish behavior in people just like you can in rats, although I have to admit, rats learn it in usually 2 or 3 trials. People take about 10 or 15 trials to learn it. We're so much smarter than rats are. What about the ethics in this? Medical safety, stopping rules. The issue when you're doing these studies in people, particularly in outpatients, is how are you going to decide that, in fact, you have to stop doing your trial either for that particular individual or for the whole study. And so that's the kind of distinction you're making, an individual patient being stopped in the study or the whole study being halted. Low antibody titers after vaccination in more than 50% of the people generally will stop your study. That is, you're simply going to not enroll. You have to decide what number that's going to be. Usually that's a number that's someplace around 30. That is, if 15 out of 30 people are getting fairly low antibody levels, then you simply have to say your vaccine isn't worth testing anymore. Okay? That evolved from the studies I'm going to show you. That's not necessary. That was not known ahead of time. The duration of the blocking antibodies is too brief. That is, if you're getting less than 4 weeks of blockade from your antibodies, then it probably means your antibodies are not that good. Once again, you would stop the study. Number of subjects to do that is an ethical decision that has to be thought about. How many subjects do you want to go through before you say that? In this issue of duration, obviously Gary was talking about people being, or animals going out to 60 weeks. That's extraordinarily long compared to what we found in the human studies. You simply don't. We never got even close to that. We could detect antibodies, but they were not at therapeutic levels. Cardiovascular safety from attempts to override the blockade. This is something that's quite real. People would, when we were doing these studies, come in. We asked them, how are they doing? And they said, well, I'm not getting high at all. I'm getting this great pounding and chest pain. So, something's going on, but I'm not getting high. I'm sure that it's my cocaine dealer's just giving me bad stuff. Even though we told them this is a blocking medication that you can expect you won't get a high, but you might get some peripheral effects from it still. Why believe the investigator? They thought it was the drug dealer. The human laboratory cocaine administration studies, I showed you about the high. The other thing that we found in that study was that when we did override the antibodies, that is when we gave a high enough dose that you were getting only a 50% reduction, those people who in fact did get the 50% or did not get a reduction, okay, because that's an average that I was showing you, those people did in fact get cardiovascular effects and did not get much of a high. So even if they got some of the high block, they still could get peripheral cardiovascular effects. So that is an issue with this because it's confining the drug in the circulation. It's keeping the drug from rapidly getting into the brain, but it's not completely blocking the slower effects of these drugs, the drugs that are cardiovascularly important, and you could in fact die from an overdose, yet not get very high from it. One of the things that we did find, and that is going to have to be an issue to think about in this, is that we've had urine toxicology levels that would come back in people that were roughly 100 times above the levels that we would see in overdoses. That is, we had people come back with urine cocaine metabolite levels of about 1 million, when any kind of drug, any kind of level above 100,000, you'll basically only see in dead people. So when we asked them what was happening, they said, once again, have a bad drug dealer. I'm using a lot of cocaine, but I don't seem to be getting high from it. I think this is going to be one of the things that we're going to have to think about. Rats learn from experiments in 2 to 3 tests. People learn a whole lot slower than that. Somehow or other, having a big cerebral cortex does not contribute to greater intelligence when it comes to the use of these drugs. And overdose is a real possibility. Okay, well, can you smoke enough to overcome the vaccine antibodies? It may take some effort, but yes, there are a number of people who are capable of doing remarkably creative things to get lots of drug inside of them. The best thing we have working for us is that at least with cocaine, it's relatively expensive. Opiates, of course, that's not quite the same limit, especially with fentanyl. So that's one of the challenges we're having now in working on these fentanyl vaccines. What about recruits for experimental anti-cocaine vaccine? We initially were going to do our studies also with normal subjects. This was now back over 25 years ago, and the FDA at that point said, no, we only want you to do it in people who are exposed to this drug, who have a risk of this drug anyway. At that time, we had to do the studies inside of a locked residential facility, though, where they had to remain for at least the duration of the vaccinations, and so they were in the hospital, or they were in a residential setting, locked doors for basically 3 months. As you might expect, that wasn't the cheapest thing in the world to do, but that's the initial studies were done that way. Later studies, they were more flexible about. I'm not sure what's going to happen this go around. But young, healthy normals, which is what you would usually do vaccine studies in, were, I don't think, ever going to be allowed to participate in these types of studies. Precipitated withdrawal risk. This is something that has been a concern, particularly with opiates, since you're giving a vaccine. If that vaccine fairly rapidly can produce high levels of antibodies, and these are people who are opiate dependent, at that point, you potentially could precipitate opiate withdrawal. Is that a severe risk? Yes and no. Opiate withdrawal is a bad case of the flu in general, so you're not going to die from it unless you're medically compromised in some other way. So we don't think it's going to be a serious issue, except in the sense that if they do in fact get precipitated withdrawal, finding more volunteers to take your vaccine may be a bit of a challenge, and so we're going to have to be thinking about how that's going to work out. Abstinent subjects versus abstinence initiation in active users. In general, we found it worked much better with people who had been abstinent for at least a couple of weeks before we started the vaccination. So they, in fact, had some motivation to want to stop using the drug. We did our multi-site national study with anyone who wanted to get vaccinated, we did. And we vaccinated hundreds of people, and including many who were, in fact, actively using cocaine. It does not interfere with making the antibodies. They still made antibodies, but in fact, those people who were actively using did not seem to do as well. So that you can do it, but this is probably going to be a bit of a challenge. It's a much more a relapse prevention type of intervention than these vaccines are abstinence initiation. Medical and psychiatric exclusions. Many of these may seem obvious, but you don't really want to bring somebody into a cocaine vaccine study that's had 2 heart attacks before, for the kinds of reasons that I've talked about. The psychiatric exclusions in general, people do get quite paranoid with these drugs sometimes, so in general, psychotic patients have been excluded from these studies, and one can expect that that's going to continue. Part of that's going to be how well can you get an informed consent from someone who's both major psychiatric disorder and has a substance abuse problem. Where is this the biggest challenge? Depression. Depression occurs in about 1/3 to 1/2 of these patients. So do you want to exclude everyone that's got a history of major depressive disorder, everyone that's had a history of overdose associated with possibly a suicide attempt? If you do that, particularly with the overdose potential with the people who've abused fentanyl, you could easily exclude 70% of the people. Many people who've used fentanyl have had overdoses. You're seeing the number that die from them. A lot more of them get overdoses and don't die from them. I don't think we'd want to exclude them from studies, but that's a question. Then finally, do you want your early studies only want to have men or women who are incapable of getting pregnant? Probably. Almost all vaccine studies, you do in fact make a change in their immune system that's lifelong. Even though the antibody levels for this type of vaccine are only going to last, I mean, maybe they'll last for a year or so, but more likely they're going to last for a few months. but you have changed their immune system. The reason that you would do a different response here than you'd get, say, with infectious diseases is what you're making the vaccine to is tetanus toxoid or cholera toxin or some other toxoid with the drug of abuse attached to it. That is not something that occurs in nature in any normal way. So it's not like a tetanus vaccine or a cholera vaccine where you can have other kinds of exposures in the natural environment that will reinforce bringing the antibody levels back up. But you have, in fact, selected out a group of B cells and made some changes in your T cells, made a change in your architecture of your immune system once you vaccinate people like this. Would this be terrible if this was transmitted with a pregnant woman? Well, the answer is pregnant women may end up being a target for who you'd want to vaccinate if you're thinking about that fetus, because, in fact, a vaccine will prevent the drug of abuse from getting into the fetus also. So it's another nice ethical question that comes up, and did come up when we had these discussions, and at the end of the day, back then at least, concluded that pregnant women who were substance abusers would probably be candidates for this. All right, some of the other things that have been considerations. Socially stable for a 6-month study. It takes, with the cocaine vaccine and with the nicotine vaccines and most all the other vaccines that have been looked at, 2 to 3 months of initial vaccination and boosters to get the levels up there. So you don't want to just give half a treatment to somebody. You would like them to participate in the full treatment. So you want to get some people that have reasonable social stability. If they're dependent on alcohol, opiates, or benzodiazepines, in general, these were people who, if they had dependence on these drugs, were excluded from the cocaine studies. Is the same thing going to happen with the opiate studies, that we should exclude the people who are getting alcohol, benzodiazepines, or, let's say, stimulants of any sort? My guess is with the benzodiazepines, the answer will be yes. Why is that? Benzodiazepines and opiates together are a good way to kill yourself, and they are, in fact, a real danger. And in the new guidance from the FDA, doctors are told not to co-prescribe these drugs. So my guess is anyone who's got a benzodiazepine problem are probably going to be excluded. Motivation for abstinence versus payment for participation. Many of these studies that are done in substance abusers, the way you get people volunteering is that 2 things are happening. Their mother, the police, their employer, their spouse are saying, fix up your drug abuse or take a walk. So there's a little external pressure. The other thing that happens for participation is we pay them to participate in these studies. We don't pay them necessarily to be getting better, but we pay them to show up. What level does that induce coercion in subjects, and how much can you pay them, for example? If you pay them $5 every time they come in, that's quite a bit different than if you pay them $5,000 to participate in the study. Because many of the people who are going to participate are not in your higher socioeconomic groups. You do select out for those folks for a whole variety of reasons, and paying is an issue. Treatment adherence. You do need very good treatment adherence to come in and get the vaccinations when you're supposed to get the vaccinations, even if there's only 3 of them. And urine tests. You want to get urine tests at least once or twice a week for the whole duration of what might be a 6-month study. If you've ever had to comply with anything where you even have to take pills for once a day for 6 weeks because of the infection you got, I won't ask you to raise your hand how many people only made it to about 4 days and then said, I feel better now, that's good enough. It's not easy to get this level of compliance. Other concurrent treatments during the 6-month clinical trial. Almost certainly we're going to need to allow that if it's going to take 2 to 3 months to get the boosters and all these initial vaccinations in. Otherwise, we just won't retain the people. We could, of course, have them physically contained in some way, which is the way we had to do the initial cocaine studies. The problem is the best way that we contain people right now is the way that half our prisons are filled up with, which is substance abusers. But in general, anybody who's a prisoner can't participate in any kind of clinical trials. So that's something that's been in place for years now. It's in some ways unfortunate, but it's because ultimately they may be the best population to be using these vaccines with. All right, so what we did in these studies, treatment-seeking cocaine users, at least 2 weeks of cocaine abstinence before they were vaccinated. This was a relapse prevention treatment, had a large target population, since the probability of relapse within 12 months after an initial quit from cocaine is about 95%. You were seeing statistics that were shown up there of 40 to 60%, that might relapse. That's an optimistic projection. And it's probably, if you take all comers in opiates, you may get something like that. It does not look anything like that with stimulants. It's a 95% relapse in 12 months. So you never run out of patients since we don't have any treatments that work either. And of course, as Mark Twain once said, stopping smoking is easy. I've done it hundreds of times. I mean, many people stop. It's a chronic relapsing disease. So how about these outpatient trials? I'm just going to focus on the national outpatient one that we did. It was a clinical trial, double-blind, placebo-controlled, had 300 cocaine use disorder patients. They were vaccinated actually 5 times with this vaccine over a 12-week period. They were gotten urine toxicologies 3 times a week. They had antibody levels assessed at various time points. And we were targeting to get a blocking antibody level, which we had calculated from our previous studies. That would be about 43 micrograms per milliliter, let's just say over 40. And we knew that this was sufficient to block 2 doses of cocaine, which was, if you're interested in stopping, that's good enough. So what did we get in terms of antibody titers? Well, I think this is the part that's probably the most problematic of anything that we're going to find when we get into humans. If I showed you the distribution of antibody titers in the mice or the rats, it wouldn't look anything like this. It would look very tight and nice. Even if you take Sprague-Dawley, which are outbred rats, they still have very tight. People, on the other hand, you vaccinate them all the same, and you get a range from practically none up to 250 micrograms. 250 is a huge amount of antibody. So that what you're seeing is, if we were making 40 our cutoff, which was what we had, you can see that maybe half of the people are going over that, and they're going way over that or little, but half of the people ain't making it. So that, in fact, we certainly need improved vaccines, but we also have to take into account that the variation across people is going to be huge. And how we select people who are going to be responders is not obvious at this point. Anyway, in this national study that we did, though, the average mean was almost 60 micrograms per milliliter at week 16, which was better than we hoped, but there was this wide range. There was no simple correlation, unfortunately, with that the higher the antibody levels, the less cocaine they used, which we had found before this, but didn't find in this national study, probably in part because all the previous studies had enrolled people who had at least 2 weeks of abstinence. This national study did not. Took all comers, and more than half of them were people who were actively using. In fact, I'd say 3/4 of them were actively using when they entered the trial. What we expected was those who got above the 42 micrograms per milliliter, they'd have more participants with 2 weeks or more of abstinence and more cocaine-free urines. What we found in the study, if we looked at sustained abstinence, which was antibody levels that they had greater than 42, they did have 3 times higher rates of at least 2 weeks of sustained abstinence. In fact, you could look at 3 or 4 weeks and you'd still get that same number. The problem with it was only 15 patients had this high rate. Most people, when they get these vaccines, hope springs eternal that they're going to find the right dealer who will override, and so they're constantly testing it out about every 2 weeks or so, even if they have a fairly robust blockade. People learn very, very slowly, and it's a very intermittent reinforcement. So these kinds of sustained abstinence criteria for FDA approval, we're increasingly working with the FDA around. These are simply unrealistic for real human beings in the real world. They just don't operate that way. That maybe they could get sustained abstinence after a year or so on these vaccines. But the vaccine antibody levels would take multiple boosters to get you out that far. And in general, you're not going to be able to do that in the early studies. What about this? Cocaine-free urines. We did find that compared to the baseline, the people with the high antibody levels did in fact have a significant reduction in the percentage of cocaine-free urines. Two things that you can see that are unimpressive is that percentage is going up to a whopping 25%. Now it was better than it was at the baseline, and so you did see a significant difference, but the baseline was not the same for the three groups, and so that screwed up any statistical analysis. So overall on this outcome measure, it would be considered a failure once you adjust for that baseline. So treatment retention, though, was better for the people who got the vaccine than the placebo. We did have these 3 times higher, more antibody and vaccinated people who were cocaine-free and lower cocaine positive rates in those people who got the higher antibody levels. But this was not sufficient to convince the FDA or for all of our investors to continue to press on, because we would have had to do another phase 3 study. So this study, after a 20-year legacy, basically bit the dust. The good news about this study, just for those of you who might still want to be optimistic, is we found that if we mix this vaccine with an enzyme that we now have called a cholinesterase, which breaks down cocaine, those two things together are unstoppable. We cannot infuse cocaine fast enough into those animals to get any effect from cocaine whatsoever, because the vaccine by itself can in fact be overridden. The enzyme by itself is actually too slow to deal with the rapid entry of cocaine into the brain, but when you put the two together, the vaccine initially stops the cocaine, and then this enzyme is constantly acting to break down the cocaine so that the enzyme, your antibody, remains available for no matter how much cocaine goes in to work. It answers the question, by the way, that was asked before about, well, where is the cocaine, where is the opiate going to go, or where's the cocaine going to go? The binding of these things to the antibody is not irreversible. It's on and off, on and off, on and off constantly. It's simply, if you have a very high affinity, the on time is a lot longer than the off time. So when it comes off, it's for a very short duration. But when it comes off, if it happens to be in the liver, it'll get metabolized to an inactive metabolite. If it happens to be in the kidney, it'll just be excreted. And if you have an enzyme in the bloodstream that breaks it down, like you have with cocaine, every time it comes off in the bloodstream, it gets metabolized to an inactive metabolite. So in fact, very high affinity doesn't mean it's glued on. It's not a covalent bond. Okay? It's a bond that, in fact, on and off, on and off, on and off, in nanoseconds. I mean, we're very, very rapid, but a lot of these things are happening very rapidly. So some of the ethical issues related to this, you got a lot of individual variation. How are we going to deal with that? Since it takes 6 to 12 weeks for initial vaccination to be effective, it'll be great if it turns out the way that this new vaccine for opiates is looking. One vaccination is all you need. I sincerely doubt that that's going to be the case. We certainly have had much more robust responses in the rodents than we ever get in people. Would you want to use this in the community as a preventative interaction? The duration of the antibody response, in our experience in people, is no more than about 3 to maybe 4 months. If you wanted to give this as a preventative intervention, that would mean you'd have to revaccinate people, boost them again. With a single dose would do it about every 3 months. If you don't have a problem with cocaine or opiates or something else, the likelihood of somebody coming in every 3 to 4 months to get a new vaccination when they don't feel like they have a problem is vanishingly small. It's hard enough to get people to come in for their tetanus, diphtheria, et cetera vaccinations, and that's years apart. So That's just not realistic. And the ratio of those who become dependent on these drugs to the number that use them or have experiment with them for cocaine is about 7 to 1. It's even much higher for opiates. That is, there's a lot, I won't ask you to raise your hand, but I bet that there's probably nobody in this room that's never been exposed to opiates. I mean, if you ever had your teeth done, if you ever had a doctor where you broke an arm or anything, they all give you a 2-week supply of opiates. Now, you may only take 2 days worth of them, but you've gotten lots of exposure. So the odds of, in fact, what is the odds of people becoming opiate dependent? It's actually relatively low. It's not the 2 to 3% that Purdue Pharma made their fortune with, but it's, in fact, in selected populations, it can be as high as 30%. But it's more frequently about 1 in 10. All right, so 1 in 10 people who get exposed to opiates in some setting where they're going to take it, taking it is the key, for more than a month. If you only take opiates for 2 days, you just don't get dependent. You have to take it for a long period of time at a regular dosage, or you'll not get any withdrawal symptoms when you stop it. And that's what drives things. The risk of dropping below the threshold antibody level and override attempt, this is an issue with all of these vaccines. We don't know exactly when somebody's level is going to drop down. Some people will drop down within about 6 weeks. Other people may go 6 months. We have no predictors of when that's going to be. And unless you want to measure their blood levels every 3 to 4 weeks to track that, which hardly anyone's going to agree to, you're not going to know. So it's just going to happen. They'll have the antibody levels up. When they do fall, they tend to fall relatively precipitously. So you'll go from I'm blocked today to you're not blocked next week, which means if you decide, okay, I'm going to try to override it today, and I know that I took 10 grams of drug last week and I got nothing, so I'll start at 10 grams. You might be dead at that point because you've given yourself a massive overdose. It's got a therapeutic role, probably with dependent users and probably early abusers. The issue that always came up with the cocaine vaccine is, would people just switch to methamphetamine? It's another stimulant that you could get. The answer was nobody did. There probably are a variety of social-cultural reasons that that's occurring. The simplest one is put in something that's going to sound like a cultural slur and is going to be offensive to some people, maybe everybody, but it's always good to know you've given a productive talk if you've offended at least 1 or 2 people, which is the good old white boys in the suburbs like using methamphetamine, and the minority people who live in the cities like using cocaine. And all they like to do is fight with each other in terms of distribution. You tend to not get distribution of these drugs mixed together. Cocaine users like cocaine, methamphetamine users like methamphetamine, but the two shall never meet. So they don't switch over. And I don't think it has anything to do with the drug effects. I think it has everything to do with distribution networks and has to do, what do your friends do and where do you get it? How many people have I offended by saying that? Oh, come on, there must be somebody, at least one. No, okay. There you go, at least one person was offended. I feel better already. Okay, so let's see. All right, so one of the bigger debates that we had quite a while ago was pregnant abusers and protection of the fetus. Should those pregnant women be vaccinated? And I have to say it was a fascinating debate of the ACLU on one side and the parents groups on the other side in terms of how people's opinions were on that. High-risk families or lack of family in high-risk communities. That is, are there people who are at very high risk just because of where they live and who's their support that you ought to be thinking about these vaccines when they're at high risk of using them at age 14, 15, 16? And the consensus back then was maybe. Community immunity as a version of herd immunity. This was a fascinating idea brought up by the mayor of one of the larger cities when we were having this panel, or this book that we were writing. And he was somebody who had a background in public health. And he basically said, well, we could use herd immunity. And everybody, sort of looked at him. herd? I mean, what are you talking about? You think we're cattle or something? Well, it ends up, the concept is very simple. If you have an infectious disease, and these abused drugs do look very much like infectious diseases, if you vaccinate a percentage of your herd of cattle against that disease, you in fact prevent the spread of that disease. And the percentage is often not that high. It's as little as 30%, that if you can get 30% actively vaccinated so you can't transmit disease from one cow to the next cow, the epidemic will die out in that population, and they'll go to your neighbor's population or someplace else where in fact it's not, they're not protected. And so I said, oh, okay, well, so what then? We said, well, it's very simple. In our city, we have a lot of problem with cocaine in the inner city. We don't have much of a problem with it yet in the middle-class outward suburbs. So all we're going to need is to vaccinate about 30% of the inner city folks. What will happen is the drug dealers will be selling the drugs to people who are vaccinated, and none of them believe that the vaccine works anyway, so they'll try to get high from it. And first off, the drug dealers who sold the drugs to them will get their kneecaps broken because they're selling junky drugs. And what they'll do is turn to a new market, and the new market will be the suburbs. Okay, all right, so now you've spread it to the suburbs. Why is that? Because people in the suburbs vote. And when they vote for things like money to actually provide treatment to substance abuse care. Now, ironically, that is exactly what's happened with opiates and fentanyl, which is fentanyl has been a problem that was concentrated for quite a bit in the central cities. As it spread out into the middle-class communities, that was when the alarm about an epidemic started to happen. I mean, if you don't vote, nobody listens. And substance abusers in general don't vote. And many people in the inner cities don't vote. And that's just a terrible commentary on how American democracy works. But for all that we can complain about, money running politics, it does count if you vote, if you live in a geographic area where you vote. And so that was the herd immunity. It wasn't tested out with this vaccine, by the way, but it was in fact tested out with fentanyl. Then the other is the unintended harms. Nicotine vaccine was probably the best examples that we had of this, which is if you take adolescents, why do adolescents smoke? Well, some of it, is it to really get high from smoking nicotine? No, a good part of it is rebelliousness and just showing that they can smoke. But they do eventually, of course, get dependent on the nicotine. So if you, in fact, have it so that you're giving a vaccine that blocks the nicotine, what they will do is what I showed you in that little picture before of, of 100 cigarettes and you light them all at the same time. Well, what you do with that is you, in fact, do overcome the vaccine, but the amount of carcinogens you put in yourself at the same time is now 100-fold greater. So that that was not your intended consequence, but certainly has happened. We're seeing some versions of that now with the vaping and electronic cigarettes, where adolescents are in fact taking in fairly massive doses of nicotine, and maybe you know this already, but their marijuana, THC, is also in those things, depending on what you buy. But even with the nicotine, the amount of dosing that they get from it is quite high. They get dependent very quickly, and there are other things in these various electronic cigarettes that are quite toxic, actually. They're not carcinogens, they're instead heavy metals and other things. So this is going to be a huge problem that's going to come up. Well, I shouldn't going to come up, it has come up already. And it's a question about these vaccines. What will people do to overcome them? Oops. These are some of the challenges that, you can't test these vaccines in normals. You do have to get your target population. Abstinence rather than simply harm reduction or reduced use is not an outcome that the FDA is willing to accept at the moment. That is a real problem because that's mostly the way these vaccines are going to work, that you will gradually get people to use less and less and less, and then they'll stop. The other thing is, in contrast to many other areas where when you vaccinate for a particular disease, or when you treat for a particular disease, if you don't reach a therapeutic level with that intervention, the FDA will permit you to, in fact, not count those people in your efficacy analyses. They don't do that with the vaccines. They don't do it with infectious disease vaccines, and they've taken that same thinking and applied that to these anti-addiction vaccines. It's very troublesome, and because the blood levels, the antibody levels, are completely independent on whether someone's motivated or not motivated to treatment. We have an independent, measure of whether you, in fact, got an adequate dose of this vaccine or not. We just look at the antibody level. They don't want to accept those analyses. They say everyone who gets randomized, so that means you're going to have to get 80 to 90% of your human beings to have a decent response to these vaccines in terms of antibody levels, or you're never going to make it through the FDA. Maybe that's going to change eventually, but as of now, that's the way it goes. And this will make it extremely difficult to make this work, unless we can figure out ahead of time who are non-responders to these vaccines. Thus far, we've looked at a whole range of things. We have some genetic predictors that may be relevant, and certainly substance abusers have impaired immune systems. We do know that, but how they're impaired and which one is important. There's a collaboration I have with Harvard right now where we're looking at white blood cells from people, substance abusers compared to normals, and we are beginning to be able to make determinations based on those responses of their white blood cells, who would be a vaccine responder. We're hoping to use that in the fentanyl studies that we're hoping to get going relatively soon. Like Gary, we're on about the same track as him to get this into people. Okay, so let's see. I don't think I have that much more to say. Here we go. Well, a little bit more to say than that. The medical risks, the carrier proteins are quite safe, whether it's tetanus, cholera, pertussis, or the carrier well, Gary's using tetanus as the carrier. We're using a pertussis toxoid because it's actually much cheaper, and we're thinking of how do you make these vaccines as cheaply as possible. Tiny quantities of abused drugs in the vaccine, so even if that covalent bond happened to break, the amount of abused drug in that is nil, and the haptens themselves have no psychoactive activity. It is a covalent attachment to the carrier proteins. What are the benefits? It is sustained. I mean, if we can get it sustained for a year, that would be remarkable. But it's a reversible blockade. There's minimal compliance needed compared to most other treatments that we have for substance abuse, where you have to at least take it. Well, there are some depot medications that are once a month, but most things are at least once or twice a day. And there's no direct brain effects or side effects. These vaccines are remarkably free of side effects. I mean, the only side effect is the drug itself when you take huge amounts of it to try to override it. So I've tried to go over a bunch of things to kind of set the stage for the ethical issues. Hopefully haven't simply said everything you were going to say anyway. I doubt it. But perhaps it would help if I went over it one more time. Not too many of you look like this particular picture, but I'm happy to answer any questions that you have. Thank you very much.
If the frequency of boosters is such an issue for a lot of your population, have you tried teasing out specifically people who were compliant with an Alcoholics Anonymous style program? People who are really motivated to stay off, have been abstaining for a while, have some social support. That seems like it would be an ideal population for you.
The simple answer to your question is yes. We didn't quite take the AA approach in the sense that AA for alcoholics works great. The equivalent of NA for opiates or cocaine, not as great. But we did, in fact, with the early, all the earlier studies before this big national study, the minimum requirement was 2 weeks of abstinence. For a cocaine user was good enough. So if they had that level of motivation, their outcomes were, in fact, considerably better than we got in this national study. So yes, I think that if you get people that have, in fact, if you don't have motivation to stop using, that might be manifested, say, by an AA participation, which, that wouldn't be good enough for us in the sense that if you look at AA for alcohol, it's actually only about 20% of alcoholics that engage in it sufficiently that it works. And we're looking for something that would engage, at least 50 or 60% of the population. But that's going to have to be, one of our screening, which is, if you think about it, it's about as simple as you can get, right? If you can do it somewhat on your own, then we can help you with it. But if you can't, even get enough motivation behind you, even with your mother telling you, I'm going to throw you out in the dead of winter in your house, then, you ain't ready for us yet or ready for this kind of intervention. So yes. There's someone back there.
Thank you. I find this all very provocative. But as an immunologist, the lifespan of an antibody response isn't dependent on being reboosted from the environment in most cases, but the initial production of the plasma cells, which can last, in the case of like tetanus, for 10, 20 years. And might it be a solvable problem with a different adjuvant, a different carrier, a different immunization protocol that would then give long-lasting plasma cells and not require a every 3-month boost?
Like the other question, the simple answer is yes. And there's a whole NIAID program, allergy infectious disease program, that's chasing that down. I think Gary's work, where he has his big liposome that appears to be having antibodies lasting for over a year, or at least at 6 months. Now, the level of antibodies that is produced, though, isn't that high. So that, we can also still have antibodies to cocaine out to a year, but they're at tiny levels. The levels that we need to make these vaccines work are up to about 1% of your total IgG. I mean, huge, huge amounts. And so that's what's the problem. So it's not that, of course the plasma cells are there, it's the antibodies themselves, which seem to degrade in about 3 months. They just kind of fall off, and you need something to make them again and provoke them to be made again. And so even when you have an infectious disease, let's say, you may have just very, very low levels of those antibodies. And my apologies, I'm not an immunologist, and I realize I'm talking to an immunologist. So, when you want to bite my head off after this, that's okay. I understand. But of course, you get exposed to that infectious disease agent, then the response is quick, and you make a whole bunch of, new antibody, but you don't circulate around all the time very high levels of antibodies. So, that's how I think about it, but I might, I'm happy to be educated. Oh, give him the thing he wants to educate me, please.
Well, actually, in the case of tetanus and diphtheria, you would circulate around for 10 years.
But at high levels, or?
Yes, you can't make antibodies to an infection with tetanus. There's not enough toxin to do it. But those antibodies do circulate for estimated 5 to 10 years. So it should be, now they may not be at the levels you need to neutralize cocaine, but I would think that, again, immunization protocols may be able to boost this up so it would be maintained for more than 3 months.
Well, that's what we're hoping for. And the only thing that's a little discouraging was that some of the same vaccines that we, for cocaine and for the nicotine, they were like major pharmaceutical companies made nicotine vaccines, which is why I got out of that business 20 years ago. And there were 5 of them that were out there by, GSK, Pfizer, et cetera, Novartis. And they tried all sorts of little booster strategies and adjuvant strategies, including TLR9 and TLR4 adjuvants, to prolong the antibody response and, of course, get the antibody response up. And we're not very successful at it. And this is in the human studies, even though in the rodent studies, the rodents have an immune system. Well, the rodent only lives 2 to 3 years, but they really do keep high levels up with certain types of adjuvants, particularly lipid-like ones like this. So I don't know. I'm hoping that we'll learn a lot more about human vaccine responses. Because if you look at, tetanus or some of those others, and you look at, you give a tetanus toxoid vaccine, and you then look at their antibody levels, you will see that their antibody levels stay up, but they stay up about 100 to 500-fold lower than the levels that we need for these types of vaccines. And so we've not been able in people to get them to go much past about 3 months. And when I asked my immunology colleagues about it, they said because you're going to have to get another primary push to get it up like that again. I hope they're wrong. I hope that we can, in fact, come up with the right adjuvant. But there's a whole national program that just started to, in fact, look at all kinds of different adjuvants with collaborations with big pharma to a limited extent. They'll only let us play with these. And we're screening through literally probably 100 different adjuvants right now that are looking at ways to juice the immune system to keep the antibody levels up. I don't know enough immunology to even know if that's a realistic goal or not. But it's a great question, and it's a quite a reasonable observation, obviously. Yeah, so thank you. I wish you could have educated me more, though, to tell me what adjuvant to use. I'm just kidding you.
Hi, thanks. My question is also for Dr. Sullivan, and it's kind of broadly related to both talks, so or all three talks. But when somebody stops using and they're in a period of recovery, even though there are these incredibly high relapse rates, from 40 to 95% quoted, over a long period of time, do their dopamine pictures start to look more like what looked like in typical people without a history of addiction? Or I shouldn't say typical people, but people without a history of addiction. So is there kind of a time frame where we think maybe we would need these types of vaccines as the dopamine stores are returning? And obviously, I'm sure one of the things we're trying to do, for example, like with Suboxone, is get people into a more even keel state. Is there anything like that with cocaine? It sounds like there is not, and that's one of the challenges that's facing the cocaine vaccines.
Yes, we know that dopaminergic activity tends to.
Do you want to, yeah.
As loud as I thought it was. We do think, or know, that dopaminergic activity does start to return to normal levels. It takes sometimes years for that to occur. Now, dopamine levels, when someone's on, let's say, buprenorphine or methadone, I don't know of any study that particularly looks at that. I would think that it may somewhat increase, but you're still on an opioid, so I would think that, it may never return back to basal levels. But for people who are abstinent, right, so recovery is a huge word, right? People can be doing harm reduction, and for them that could be recovery, right? They can be using small amounts of heroin, so it's hard. It's really hard. But you nailed it on the head. I think one of the things with the cocaine vaccine, I think maybe unlike the heroin one that we'll talk about later, is that in opioid therapy, the medication like MAT is linked to the therapy, right? So you're coming all the time anyways to get methadone or buprenorphine. So there's always there's multiple touch points to administer, say, a vaccine or anything to these people. Whereas with cocaine, there's very little pharmacologic medications that we give people that would prompt them to want to keep coming back to a treatment facility, all the time to get a shot every 3 months. There are some medications that show some efficacy in decreasing cocaine use, like topiramate and maybe even, believe it or not, disulfiram. But there's not any great medication. There's no replacement therapy. Now, if there was, I think that you would maybe get someone to be able to take a vaccine once every 2 to 3 months. But there's really nothing great that works for cocaine other than things like motivational interviewing and these type of things. And that's why I think it's very difficult to probably keep people enrolled in a study like this, in my opinion. But I agree with you. These things would be great for people in early recovery. And as we're trying to return their levels, get them back to normal, quote unquote, and if dopamine levels will increase, I think that would be an efficacious time to give people these things. Thank you.
Yeah, just to amplify that perhaps a little bit, the opiates are a particularly benign system. in that we've obviously had people on methadone maintenance for 40 plus years, and I've got some patients who in fact have literally been on methadone for 40 years, and you don't disrupt their dopamine systems that profoundly. You disrupt their prolactin systems, interestingly, so that prolactin levels remain up even if you're on methadone for 40 years, which in women doesn't seem to make a whole lot of difference. In men, does lead to a variety of complications sometimes. On the stimulants, on the other hand, they're much more destructive. Stimulants damage your dopamine system relatively directly, and that damage is somewhat reversed over time. That is, it stops progressing over the course of about 4 to 5 months, in that when we've done repeated PET studies looking at these dopamine receptors. However, it does not come back to normal at all, unfortunately. And if you look at Parkinson's disease in people who are methamphetamine abusers, well, these were studies done a while ago, so they were methamphetamine abusers in the 60s and 70s. They were then looked at 20 to 30 years later, and the rates of Parkinson's disease in those methamphetamine abusers is way higher than your community rates, and really reflects dopamine cell damage. You have to knock out about 80% of your dopamine cells before you get clear Parkinson's disease. These folks had Parkinson's disease without any family or other risk factors other than that they were methamphetamine abusers for periods typically of about 10 years. So I think that stimulants are destructive in a different way, and they do damage your dopamine systems very specifically. Okay, I think let the next speaker talk.